words of introduction, and at the outset I'd like to thank the organizers, Dr. Jasuja as well as Dr. Sagar and their entire organizing team, who have organized this wonderful conference not only this year but year after year successfully, and the number of participation is rapidly increasing, as you can all see in this hall from the compared to the previous year. So the question which was posed to me was ultrasound guided insertion of dialysis catheter, is it necessary? So if I have to answer this in common simple language, then it is yes, it is necessary. But as we all know, life is not so simple. We have all kind of complexities in life. So in next 15 or 20 minutes, I'll deal with all these things, and I'll say why it is necessary and in which situations we can avoid the necessity of ultrasound guided insertion. And to begin with, I'll say that we should not be inserting dialysis catheter at all. And this you have heard from the morning from various speakers also, that AV fistula should be the first priority as far as vascular access is concerned. And this is basically because of this reason, that the infection rates are high as in catheters. It is very high in non-tunnel catheters, but relatively less in tunnel catheter, but still it is very high as compared to your fistula or graft. Not only the infection rates are high, but the hospitalization rate because of this infection or other complications is also high in these catheters. So the guidelines recommend that there should be restricted use of these catheter, more so for the non-tunnel catheter, but these continue to be in common use. And according to the DOPS study, the prevalence of use of these catheters in hemodialysis is around 23%, and incident patients is around up to 75%. And Dr. Jha has mentioned previously that there is many variations in center to center about the incidence and prevalence of these kind of catheter use in the incident and prevalent dialysis patient. So this is the reality that we are using these catheters. And these are used especially when the access is required quickly, like in patients suddenly presents, patients of AKI presents with hyperkalemia and fluid overload, then we don't have any time for anything else, we have to do this catheter insertion. Or patients of CKD who are presenting very late in the stage of 5D to us, and there is urgent requirement of hemodialysis. If we are using non-tunnel catheter, they should be used preferably less than 2 weeks. Tunnel catheter can be kept for a longer duration of time, and there are a whole lot of complications of these catheter, particularly at the time of insertion, like arterial puncture, infections, hemothorax, pneumothorax, air embolism, and brachial plexus injury. So why we should be talking about ultrasound guidance? So basically, traditionally speaking, when we were using the landmark guided insertion of these catheter, the complications rate of mechanical complications were around 15%, and the insertions were unsuccessful and up to 12% of cases. So due to these reasons, to avoid these complications or to reduce the incidence of these complications, people have started using ultrasound, and nowadays this is becoming standard of care. And this is to tell the residents, and many of you are aware that this is the traditional landmark technique. This is the anatomical triangle between the two sternomastoid head and the clavicle, and here lies the carotid artery as well as your internal jugular vein. And traditionally we are using in the landmark technique this kind of anatomy. But this figure has been mentioned previously also by Dr. Nair. And there is whole lot of variations in the position of internal jugular vein in relation to the carotid artery, and this is why there are chances of hitting wrong vein or hitting artery or not hitting any vessel at all, and leading on to the complications. So as high as 15% of patient can have this not a normal distribution of vein in relation to arteries. So if we talk about guidelines, this is NICE guidelines, and if you can see 1.1, then the use of ultrasound guidance is recommended if you are putting any catheter in internal jugular vein, or it should be considered in most clinical situations, especially if they are elective, but more also in the emergency situation. And it is also recommendation as per NICE guideline that those who are involved in this practice should have a appropriate training of this ultrasound guidance insertion, but they say that Doppler is not necessary. You should just simply use the simple ultrasound and not the Doppler ultrasound. If we talk about the CARI guidelines of Australia, then they strongly recommend that we should be using the ultrasound guidance for putting all these catheters in the internal jugular vein to reduce the rates. And they have also given these figures that when we use the ultrasound guidance, and I'll be talking about this later on also, that what are the advantages of ultrasound guided insertion over and above the landmark insertion technique. If we talk about the KDOGI guideline, then they say that the ultrasound guidance is recommended to reduce the insertion related complication. That is evidence/opinion based, and it should be used preferably, especially if we are using the internal jugular vein. ERBP guidelines again say that insertion should be guided by ultrasound. Coming to American Society of Anesthesiology, this is the only recommendation where they say that it should be used, but it can be avoided in the emergency situations or whenever there is any clinical constraint. When the ultrasound facility is not available, you can still go ahead and put these catheters, but it should be preferably used under put under the ultrasound guidance. And all these guidelines are based on this review, Cochrane meta-analysis, which was published in 2012, and earlier also it was published for the base, and this is the basis of most of the guidelines. And what this review has done, this has selected all the randomized trial which have randomized patients into ultrasound guided versus landmark technique insertion, and compared the complications rate and come up with a meta-analysis, and this is the basis of all the guidelines. And if we see the first if we see overall, that is what is the outcome number one, that is failed catheter insertion overall, including whatever number of attempts you have made. Then if we are using ultrasound guidance, then there is as high as 89% risk reduction if we are using ultrasound guidance. And amongst this all randomized study, there is only one study which was done by Dr. Ravi Bansal from All India Institute of Medical Sciences in 2005, and this trial has been included in this meta-analysis. And there is 89% of risk reduction if we are using ultrasound guidance in failure of insertion. And if we talk about failure of insertion at the very first attempt itself, then there is 60% risk reduction if we are using ultrasound guidance. If we talk about arterial puncture, then there is about 78% risk reduction. Then there is around 78% risk reduction if we talk about arterial puncture. But there is surprisingly, there is one trial which has mentioned that that the arterial puncture rates are more in ultrasound guided insertion as compared to the landmark technique. I don't know what is the reason why they have found more incidence of arterial puncture, but otherwise all the guidelines as well as all the trials as well as meta-analysis have shown that there is reduction in arterial puncture if you are using ultrasound guidance. If we talk about hematoma, then again there is around 73% risk reduction of using by using the ultrasound guidance. And if we talk about pneumothorax and hemothorax, then again there is around 77% risk reduction if we are using. So all kind of complications are significantly reduced if we are using ultrasound guidance. This is on the basis of randomized trials, and this is on the basis of this meta-analysis. And this is the meta-analysis which have forced all the guidelines to include the ultrasound guided insertion as a mandatory requirement in the for putting the these catheters. And what I have not been projected here is that the time which is required to insert this catheter is also around 1.5 minutes less if we are using ultrasound guided insertion as compared to the blind insertion. So why it is so that ultrasound guided insertion is better and it is recommended? Because it readily identifies the location of your vein in comparison to arteries, and then it can also take into account whatever individual anatomical variations are happening in a given patient. And the ultrasound guided insertion in an experienced hand significantly decreases the number of attempts in the arterial puncture, and that is why it is the preferred method, especially if you have difficult catheter insertions like patients who are obese, who have short necks, or who are hypotensive. These kinds of patients, ultrasound guided is of a great help. So it is safe, it markedly decreases the complication rate, there is real-time visualization of target, and you can actually see the needle entering into the vein, and thus you can be very sure that you are actually putting your catheter into the vein and not into the artery or any damaging any nerve or any. So this is the ultrasound finding, if it can be projected better. So there is a vein in relation to artery, and this vein is usually compressible. And that shows that you are actually dealing with the vein, and your vein is also patent, and it is not thrombosed or it is not occluded. If it is thrombosed or occluded, it will not be compressible. So compression confirms the patency of, I think this is again hanged. So if the vein is collapsible, then it confirms the patency. And second advantage is you can actually see the needle tip which is entering into the vein. You can see into the longitudinal or into the transverse direction. You can actually visualize your needle which is entering into the vein. So there are two techniques of ultrasound guided insertion. First is just marking technique, where you can use a 5 to 10 mH probe. You locate the vein, ensure its patency, ensure that it is collapsible vein, and then you make the markings by your marker pen or whatever, and then puncture the needle, puncture the vein in a blind technique. But this technique has not been shown to be as safe or more safer as compared to your landmark technique. So what is recommended is a real-time insertion of guided by the ultrasound, in which you can actually see the needle tip and actually see the needle tip entering into the vein, and this actually prevents the mechanical complications. So you can use either transverse or longitudinal orientation of ultrasound probe. I have shown you both the longitudinal and transverse, but because the transverse gives the better view of the needle entering into the vein, it is initially preferable, especially for the novice clinicians. And we can also use the help of needle guides which are there in the ultrasound machine, which gives the direction of the entering of the needle to guide your needle entrance. There are certain pitfalls of ultrasound use. First is it may fail to identify your veins correctly, and failure to localize needle into the tissue. And there are certain tips for a successful ultrasound guided insertion. What happens is that if you have marked and if you have looked into the patency of your veins, and after that patient has moved a little bit, and that will change the entire anatomy in the neck. So if the patient has moved, then you have to again check about the vein and artery relation. You have to centralize the vein in the middle of the screen and not at the side of a screen. And whenever you are dealing with the vein, you don't have to push the probe into the forcefully, because it will collapse your vein and you will not be able to see, and you will mistake the artery for vein actually. So you should lighten the probe pressure, and you should insert the needle at a sharper angle of 45 to 60 degree rather than at a 90 degree or in a flat angle. So basically it gives you a better view of the needle. And the steps to success: you should use adequate gel. You should confirm the orientation of probe. Conventionally, it should be pointing towards the right side. We should do preliminary ultrasound to find the patency of vein, mark the sites, and use sterilized technique. And how you do sterilized technique, and if you are using ultrasound, is that you apply normally whatever gel you are using, you apply it to the probe, that is a non-sterile gel, and then slip the sterile sleeve which is available commercially over this transducer. Smoothen all the air bubbles away from the scanning surface. This is to prevent artifacts, and then secure the sleeve at the end of the probe wire with the use of rubber band, and then you can do the ultrasound. So the question is for all of you, which might be coming in the mind of you: is ultrasound necessary? Giving all these kind of advantages and techniques involved, is it necessary or essential in all the cases? Yes, it is. It should be preferable in all the catheter insertion, but may not be necessary in few selected settings. This may be if you are putting catheter in urgent situation, like I mentioned, patient of AKI presenting to you with hyperkalemia, and you have to insert a neckline, and patient is you don't have ultrasound facility, then you can go ahead and do a non-ultrasound guided insertion. Then this can be avoided if ultrasound facility is not available at all. But you have to remember that there is always a learning curve when we are dealing or we are learning with the help of landmark techniques or anatomical guided insertion. We all have a learning curve, and initially in the initial phases there will be increased rate of complications by this landmark technique. Then inexperienced hand, there are few reports that inexperienced hand, the rate of blind insertion complications are as good as the ultrasound guided, but this is only with experience. You can't go away and start with same rate of complication. And another situation, if you are using your catheter insertion in subclavian vein, then again, this is not mandatory to use ultrasound guidance because it doesn't give a good view of subclavian vein. It is mandatory for IJV insertion, but not for subclavian insertion. So this is a study which was done in PGI when we did not have any routine availability of ultrasound in our dialysis machine. Nowadays we have routine ultrasound machine is available routinely in our dialysis room, and we are doing all the catheter insertion under the ultrasound guidance. But there was a time when it was not routinely available, and we were forced to insert dialysis catheter without ultrasound guidance. And that time we had inserted around 230. When we analyzed around 233 non-tunnel catheter insertion in the internal jugular vein. And the majority of catheter were inserted because of AKI presenting in emergency situation, but around 42% were inserted because of late presentation of CKD, and there was no time to make a fistula. And that time, and this is around 3-4 years back, and that time we were not very frequently using the tunnel catheter, so we were preferably using this non-tunnel catheter. So 177 insertion were because of newly detected renal dysfunction, 15% were because as a bridge to ambulatory peritoneal dialysis, 3% for awaiting AV fistula maturation, and there are other indications also. So if you see what were the rates during that time. So successful catheterization at first attempt was successful in around 79% of cases. And failed catheterization despite number of attempts, 3 attempts or 4 attempts, maximum were 4 attempts, were there in 4.3% of cases. Now, if we talk about ultrasound guidance, then what is recommended that if you are using ultrasound guidance, your failed catheterization rate should be around 1%. But whatever most of the trials are mentioning is their failed catheterization rate is around 2 to 3%, and ours was 4%. So it was slightly higher as compared to the ultrasound guided insertion. The insertion complications were noted in 12.8% of cases, out of which traumatic complications were around in 10.7% of cases. And arterial puncture was 5.2%. Now, what is recommended by use of ultrasound guidance is your arterial puncture rate should be around 2 to 4% or less, as low as possible. And traumatic complications rate should not be around more than 5% or 7%. It should, so we had noted more traumatic complications, we had noted more arterial puncture, hematoma was around in 3% malposition, and all sorts of complications which have been reported. So what I mean to say that whenever we were using non-ultrasound guided, we had noted a more successful or a comparable success of insertion of catheter, but at the cost of a slightly higher complication rate. So to conclude, ultrasound guided insertion of hemodialysis catheter is now a standard of care. So we should always try to go for this, that we should preferably use ultrasound guidance, and it is recommended now by all the guidelines. Nephrologists should get a training in ultrasound assisted insertion. However, in emergency situation or resource constraint setting, landmark assisted insertion can be reasonably safe in experience, but it always comes with a learning curve. Thank you for your attention.